A very good evening to everyone. And at the outset, before I begin, I'm going to take this opportunity to congratulate the organizers and also thank them for the opportunity. A special word of mention to Roxaman sir for putting together this wonderful academic event. So I know I have this onerous task of doing this panel discussion all by myself. So I've never tried doing that, but let me see how it goes. So as far as the incidence of EGFR mutation is concerned, we all know that it's around 20 to 30% globally, and it's more common in never smokers. And most of the commonest EGFR mutations usually happen between exon 18 to exon 21. And then the less common or uncommon mutations, as you would call it, actually happen in exon 18, which is the G719S, or the exon 20 S7681 mutation, and the other being exon 21 L861Q. And sometimes you can have complex or compound mutations or even co-mutations happening as well. So quickly, I know we've had a lot of discussion in the metastatic setting, so I'm just going to quickly brush through the data in the adjuvant setting for the use of EGFR inhibitors. This was the early data, the Chinese Thoracic Oncology Group, the adjuvant data, which was a phase 3 trial looking at patients, enrolling patients from China. And the randomization was again between Gefnib versus chemotherapy, and that's what made it interesting. The primary endpoint being DFS. Baseline characteristics were again pretty evenly matched in both the groups, and this was the overall survival. And let me again remind you that the primary endpoint of the study was DFS. This was not powered adequately enough to answer the question of whether it could show an improvement in overall survival. But having said that, you can see that the curves are almost hugging each other. But probably what I would say in clinical practices, would this be relevant? An absolute improvement in survival of close to 12 months, 75 versus 62 months. So probably yes, I would take that with a pinch of salt. But still, let's get on to that, and I'll probably tell you why. And let's look at the 3-year and the 5-year updated disease-free survival rates. And you can see that there's an absolute improvement again of close to 11 months. However, this was statistically significant, and this was powered adequately to answer that question as well. And going by the post-hoc analysis, depending on the duration of adjuvant EGFR, first generation EGFR TKI, so patients who went on it for more than 1.5 years seem to benefit, whereas patients who went on it for less than 18 months did not seem to derive the same magnitude of benefit. And here the entire total duration of Gefnib was for 2 years, as opposed to 4 cycles of platinum-based doublet. So let's look at the other study, very similar design. This was the IMPACT study, and this was Japanese data. So we all know that the LACE meta-analysis has clearly established cisplatin-based doublet as the treatment of choice as far as adjuvant chemotherapy is concerned. That has shown an improvement on 5-year survival of close to 5%. So let's look at how that happens, or how the EGFR conundrum actually fits in there. So here again, the randomization was between Gefnib for 2 years versus a platinum-based doublet, which was cisplatin versus vinorelbine for 4 cycles. Here also the primary endpoint being DFS and secondary endpoints being overall survival. And interestingly enough, looking at the rates of treatment completion, there was nothing much to choose from here, but the discontinuation rates surprisingly were higher with the first generation EGFR TKI, 40 versus 20%, almost double. But again, as you could see here, most of them was because of progression of the disease, relapse or second malignancies, close to 16%, and adverse events were only 12 versus 8%. And again, the DFS, the primary endpoint of the study, even though it did show an improvement of close to 11 months here as well, but this was not statistically significant. Look at the hazards and the p-value. This was not statistically significant. So again, I think this has got to do with the numbers. Again, less than 200, close to only 200 patients were enrolled on this study as well, and this was probably one of the reasons as to why this primary endpoint was not met, and probably it was not powered adequately. So I'm not sure if they can see a difference between both the studies, but probably this is just goes to show that statistical jugglery can actually make one trial look better than the other. So this is just a cross-trial comparison between these two studies. Look at it in terms of absolute improvement. I know these are only cross-trial comparisons, but still 11 months improvement in the DFS in both the studies. But one was a positive study and the other was a negative one, at least as far as the primary endpoint was concerned. And again, moving on to the subgroup analysis, well, clearly again, as you can see, Gefnib seemed to be doing better in most of those patients as opposed to platinum-based doublet, and no improvement in overall survival. Again, like I said earlier, it was not powered adequately enough. And again, subgroup analysis also definitely did not show any magnitude of benefit with Gefnib. And the adverse events, nothing much to choose from, something that we've always known with EGFR TKIs, which is skin reactions, diarrhea, which are all class side effects. But I know this is something that always gets debated on. Suppose what if your patient cannot afford osimertinib in the adjuvant setting? Would you then put them on EGFR TK or a first generation EGFR TK? And are you actually letting them selectively develop brain metastasis? So, the way I would look at it is, first of all, the patient has got to live long enough to develop brain metastasis. So I think then comes the question of whether, we're letting them selectively develop brain metastasis. Because remember, when you're talking about survival, 5-year survival for somebody with even stage 1 non-small cell lung cancer, it's only to the tune of around 50 to 55%. And that's Western data in a developed country. So that is just to put things in perspective. So you're not wrong in actually offering an adjuvant gefitinib as well, or even a first generation TKI in somebody who cannot afford osimertinib, or in somebody who's not fit for chemotherapy at that point in time as an alternative to chemotherapy, adjuvant chemotherapy. And the subsequent treatment as well, this was how it was. I mean, like patients who had the chemotherapy also subsequently went on and had TKIs. So that's how it, and osimertinib, we all know in the second line is approved only for patients who have a T790M mutation. So again, the impact study, to summarize, again, was a negative study. So we have one positive study which met its primary endpoint of DFS, another study, even though the magnitude of benefit was similar, statistically not significant. Like I said, a lot of statistical jugglery was on. So again, I think the key points here, and I try addressing all these points myself. What percentage of patients usually present? It's less than 10%, 6 to 8% only, and that's based on the TMH data as well. I don't remember the last time when I saw somebody presenting with operable lung cancer, because remember, resectability and operability are two different things. Resectability, basically means that anatomical or radiological resectability. But when it comes to operability, there are a lot of other factors that go into it as well, like the patient's age, performance status, comorbid conditions, all of them. So I think that's why you call it operable lung cancer, and then that's less than 10%, only around 6 to 8%. What proportion will be EGFR mutant in the adjuvant setting, or with localized lung cancer? I'll show you the data as well as we move along, but it's only to the tune of around 10%. Historical control showed it to be around 20%, but now we have data to show that it's only around 10%. Role of predictive radiogenomics, again, there are a lot of studies looking at that as well, meaning just can you predict someone to likelihood of having an EGFR mutation just based on the radiological imaging or the findings. Yes, there are certain points, like for example, the ground glass opacity, perihilar distribution of the lesions. So, there are a few pointers, but again, that's a work in progress. You cannot rely on that completely. What percentage of patients go on to receive adjuvant chemotherapy? And that I'll address it in my next slide as well. Because if you look at the ADAURA data, which, has now become standard of care, adjuvant osimertinib is now an approved option. Even in that study, only around 50% went on to receive adjuvant chemotherapy, and the remaining 50 went on to receive osimertinib straight away. So is it practice changing? I would say yes, at least for those patients who can't afford osimertinib, yes. And this is the data that I was alluding to, the prevalence of EGFR mutation testing and the incidence in early stage or in up to stage 3. So like I said, only around 10%, which was about half of the anticipated 20%, which is what was looked at as historical controls. So then again, I think the key question about ideal duration of treatment, do you just do 2 years, stop at 2 years, or do you continue until progression? Again, that's an unanswered question, because the ADAURA study looked at 3 years, whereas the other two studies which I just presented now, the adjuvant and the impact, only looked at 2 years, and that was a direct comparison with chemotherapy. Overall survival data, agreed, yes. These two studies, the first generation EGFR TKIs, have not shown any overall survival data, but remember, they were not powered adequately also to show that. So remember the difference in numbers. These two studies had only 200 patients. ADAURA had 600 patients, which is why they were probably able to show an improvement in survival. And exploratory post-hoc analysis, that's only an exploratory subgroup analysis, but still, if you had patients going on more than 18 months of gefitinib or a first generation EGFR TKI, then the magnitude of benefit was preserved. Not going to get into the details too much of these ADAURA study as well, but this is the study that led to the approval of osimertinib in the adjuvant setting. The randomization was between osimertinib versus placebo, and again, patients could have adjuvant chemotherapy as well. And I'll get to that a little bit later on. Only around 15%, 50% had received, 54 to be exact, actually received adjuvant chemotherapy followed by osimertinib. But again, the key thing is that all patients with stage 3 disease went on to receive adjuvant chemo and then osimertinib. Stage 2, a lot of them went on to receive straight away osimertinib without adjuvant chemotherapy. So again, they were pretty evenly balanced, and like I said, prior adjuvant chemotherapy, 50%, 55% to be exact, in both the osimertinib and the placebo arm. So the primary endpoint, well, this was definitely met, and this was stunning. The hazard ratio, I don't remember the last time I ever saw a hazard ratio of 0.17. That translates to about 83% relative risk reduction. So that's fantastic news. And again, in the overall population as well, including stage 1B to 3A, well, again, the magnitude of benefit was preserved. Even though in practice, probably, I wouldn't want to do it for stage 1B. I'd probably want to reserve it only for stage 2 and 3. Because look at the magnitude of benefit. Stage 1B, you can see that the curves are almost hugging each other, but stage 2 and 3, the curves are absolutely split wide apart. So the quantum of benefit is definitely much higher in patients stage 2 and 3A. And again, the overall survival data is immature, which is why we've not yet seen the curve starting to separate. But probably with due course of time, we'll be able to show an overall survival benefit as well. So to me, definitely a blockbuster. So again, this is something that I really wanted to highlight. Like I said, close to around 55% went on to receive adjuvant chemotherapy in both the arms. And you can see that the magnitude of benefit was higher in patients who had actually received adjuvant chemo and followed it up then with 3 years of osimertinib, as opposed to patients who went away straight onto osimertinib without adjuvant chemotherapy. So, and again, stunning. Look at the forest plot again. Across all subgroups, osimertinib scored over placebo. And again, safety data, nothing much to write home about. Again, pretty similar to what we've seen with the earlier osimertinib data. So definitely practice changing. Adjuvant or maintenance alone, I think we'll have to follow it up. Adjuvant chemo followed by maintenance osimertinib for 3 years is the current standard. Ideal duration of treatment, yeah, the trial says 3 years. Would you want to continue it until progression? That's your guess is as good as mine. Overall survival data, again, we'll have to wait for the data to be mature. And even for stage 1B, not so. Probably from stage 2 onwards, definitely yes. And the alchemist is interesting because this is the alchemist data, which is like horses for courses. So meaning if you have somebody with an EGFR mutation or an ALK mutation, then you put them on EGFR inhibitors or ALK inhibitors in the adjuvant setting. And if they're all negative, then you put them on maintenance immunotherapy for 2 years. So that's probably, how things are going to evolve in the future, and that's how it is going to look in the future. So what about the LAURA data? This is something which we're all keenly anticipating as well. We know durvalumab now is the current standard of care for somebody with unresectable stage 3 lung cancer post-concurrent chemoradiation. But what about patients who have an EGFR mutation? Because the specific study did not include a lot of patients who had EGFR mutation positive, only around 10%. So again, I think that's a key point because we've always spoken that in patients who have a driver mutation, what about the predictive ability of immune checkpoint inhibitors? So I think that's where this LAURA study is probably looking at answering that question. So post-concurrent chemoradiation, osimertinib versus placebo, keenly anticipated results. So we'll have to wait for that. And again, what are the latest EGFR, third generation EGFR inhibitors? Because until now, we only had osimertinib, and osimertinib was unchallenged. So now we have a lot of contenders to the throne, and one of them being aumolertinib, which is again one of those Chinese molecules, if you really aren't to that data. So this was the phase 3 data, the INEOS data, which was actually pretty impressive. So look at the primary endpoint, which is progression-free survival, 19 versus 10 months, which is more in tune of what we've seen with the FLAURA data as well. And this is in patients with metastatic stage 4 in the first-line setting. So look at it. Again, in patients, even with brain metastasis, always, as we've seen with osimertinib, aumolertinib also has shown a similar magnitude of benefit. And safety profile is very consistent with what we've seen with the earlier EGFR TKIs, only the class side effects. So this was a phase 3 trial, albeit, you could always say this is unshiny data, but I guess this is something that will really make an impact in the future going forward as well. Will be a real contender to osimertinib. And is that the only third generation EGFR TKI? No. We have another one as well, which is called furmonertinib. And again, this was also looked at in the furlong study. This was another phase 3 data looking at comparing it versus geftinib. And again, you can see that the median PFS was 21 versus 11 months. And the safety profile is consistent with what we'd seen with the earlier third generation EGFR TKIs. So again, we have two contenders to the throne, aumolertinib and furmonertinib. So watch out for that space. It's a constantly evolving one. What about EGFR exon 20 insertions? I know these are mutations that cannot be targeted with your conventional EGFR TKIs, and the current standard remains in the first line a platinum-based doublet. And on progression, now we have two FDA-approved options. One is amivantamab, which is an anti-EGFR MET bispecific antibody, and then the completely oral EGFR TKI, which is mobocertinib. These are the two drugs that are currently FDA-approved for EGFR exon 20 insertions post-progression on a platinum-based doublet. And again, poziotinib, the Zenith data was promising, but not yet approved. Pyrotinib, yes, again, data looks promising, but again, it's not yet currently approved. And apart from this, I can also add yet another third generation EGFR TKI is lazertinib. We have ongoing trials looking at a combination of amivantamab plus lazertinib in patients who progress on osimertinib. So that again is very interesting data, looking out for that. And then again, before I conclude, I think we have patritumab deruxtecan as well, which is probably the only antibody drug conjugate which can target HER3. Again, that works in HER2 exon 20 insertions as well, and that's being looked at in non-small cell lung cancer. So before I conclude, I'd also want to touch on the oligometastatic space. So what about patients with an oligometastatic EGFR mutant non-small cell lung cancer? Is there a role for local therapy in those patients? And this was interesting. This was a phase 3 trial, again, Chinese data, EGFR TKI with SBRT versus EGFR TKIs only, primary endpoint being PFS. And again, the baseline characteristics were pretty evenly matched. Icotinib was used, but remember that's because that's approved in China, but it's not FDA or DCGI or EMA approved. So that's how it's already been. Probably the same thing shouldn't happen to aumolertinib and furmonertinib as well. I hope we have access to those third generation EGFR TKIs. This was the primary endpoint of PFS. Well, again, as you could see, local therapy did seem to improve on it. However, let me get to that a little bit later on, as far as was it statistically significant enough for us to actually change our practice. And safety profile consistent with what we'd seen earlier. So again, is this practice changing? Probably yes, but then would you do it for everybody? No. I think, we really have to look at patient selection criteria, because there's no fixed about definition of oligometastatic disease, because you'll have to look at defining the number of lesions, the site of lesions, and size of the lesions as well. So, I think that's how it is, up to 5 lesions and up to, not more than 3 centimeters and not more than 3 lesions in a particular organ. So I think that's one way of defining oligometastatic disease. And what about choice of TKI? Because remember, this trial looked at only using a first generation TKI. So would you have the same benefit if you gave a third generation TKI and compared it with a third generation TKI like osimertinib? Again, that is an unanswered question. And timing of radiotherapy, I think we'd probably look, given that it's stage 4 disease oligometastatic, we would probably look at seeing how well the patient responds to a particular line of therapy before we actually go ahead and give them local therapy, local consolidative therapy. And this study actually excluded patients with brain metastasis, and that's a big criticism, because we know patients with EGFR positive disease have a higher incidence of having brain metastasis, up to 15% at baseline and 30% at the time of progression as well. And what about the role of surgery as well? Is it only radiotherapy, or could you do a surgery if somebody's got an isolated CNS met? So this is a list of all, and this is only cross-trial comparisons. We have a host of studies looking at the role of local therapy in oligometastatic disease, but this was the first one, which was phase 3, and also looking at particularly EGFR mutant non-small cell lung cancer, has shown an improvement in PFS and overall survival at a pre-specified interim analysis. But however, we'll have to, there are a lot of criticisms. I'll talk about it in my coming slide. So again, there was an imbalance between the EGFR mutations and TKIs. Again, exon 20 insertion were also included. And again, they looked at patients, they excluded patients with brain metastasis. So like I said earlier, the location of mets matter, and how many sites could you end up radiating. So I think these are all key differences. So, and what about the role of other local therapy like surgery? SBRT, probably less invasive, quality of life better. But again, I think the standard arm needs to be much better than a first generation EGFR TKI. Should have been a third generation EGFR TKI like osimertinib. So with that, I'll conclude and say thank you all for your patient listening, and hand it over back to the organizers.
Thank you, sir. Thank you so much. And now I would like to invite Dr. Sumant Gupta, sir, for the concluding remarks.
Thank you, everyone. And Krupa, your talks have been marvelous recently. So you have become an excellent teacher. I think what started long back has been a tremendous journey. Thank you, everyone. Thank you, the team, for such a nice conference, and all the faculty. And I think it is time to wind up. It's been very late. I thank you, everyone, all the sponsors and Healthy Blossom event management team. Thank you, everyone, for a lovely evening. Good night, everyone.
Good night, sir. Good night, everyone. Thank you.